Welcome, everyone. My name is Jessica Desardin. I am a program coordinator in the Office of Community Engagement. We are thrilled to be back for the April edition of the C Spotlight series. I'd like to begin with a statement from the Office of Community Engagement. Excuse me. We wish to acknowledge the Indigenous people who are past and present stewards of the land on which we pursue our just cause of improving health for all. I'd also like to recognize MCW's values: caring, collaborative, curiosity, inclusive, integrity, and respect. These values guide us in all our endeavors. It is our goal and expectation that the entire session, including the chat interactions, will reflect these shared values. Please note this session is being recorded, and please be sure you remain unmuted throughout the presentation. We encourage everyone to use a chat bar to share comments or pose questions for our guests throughout the session. We will monitor the chat and address questions and comments accordingly. This monthly series features community partners and the important work they are doing. We highlight their goals, motivations, and accomplishments, and the ways they have partnered with people and programs at the Medical College of Wisconsin. Now, at this time, I would like to introduce our Senior Associate Dean for Community Engagement, Dr. Stacy Young, who will say a few words about our featured guest. Dr. Young.
Thanks, Jessica. Good afternoon, everyone. Welcome to our April Spotlight. If you're like me, you're still smiling a bit from that lovely song choice. Thank you for that. I haven't heard that song in some time, so it made me smile as soon as I heard it. I have the honor to introduce today's featured guests, Doctors George Lange and Sabrina Hofmeister. Both Doctors Lange and Hofmeister have partnered on advanced care planning and advanced directives. Dr. Lange is a retired board-certified internist and geriatrician who focused his career on educating communities about end-of-life decision-making. He currently serves on national and statewide collaborations focusing on end-of-life decisions. Dr. Hofmeister serves as the program director at the Froedtert and MCW Southside Family Medicine Residency Program. Her areas of focus include program development, resident education, and patient care focused on women's health and geriatrics. So thank you, Doctors Lange and Hofmeister, for being our featured guests today. I would also like to welcome today's facilitators, Dr. Chris Simenz and Dr. Corina Norrbom. Dr. Simenz serves as an associate professor at the Medical College of Wisconsin's Institute for Health and Humanity. Dr. Norrbom serves as an associate professor at MCW-Central, Wisconsin, and the director of the Physician in the Community Scholarly Concentration. Thank you, Dr. Simenz and Dr. Norrbom, for being our facilitators today. I now turn it over to you.
Thank you, Dr. Young. Well, and again, it's my pleasure to welcome Doctors Lange and Hofmeister. And to get us started off, I'm just going to ask you to please tell us a little bit about yourselves.
Sure, I can jump in first if everyone can hear me okay. My name is Sabrina Hofmeister. I'm a family physician. I've worked in residency education now for 12 years and some community health practice before that. Being a family doctor and practicing in both the inpatient and the outpatient setting, and also the nursing home, I've had an active nursing home practice for years now. I really see the value and importance in advanced care planning. And so many years ago, when I got connected with Dr. Lange and started doing some work within the Froedtert system and other health systems locally on advanced directives, it was really important to me to further this work and further the conversation with the community to increase rates of advanced care planning to avoid some of the headaches and complications that can happen when it's not done.
Oh, and Dr. Lange,
Dr. Lange, you're muted.
Am I unmuted now? Okay. So I'm Dr. George Lange, and obviously this has, oh, I lost the screen. Okay, I'm back. Can you hear me?
We can hear you.
Thank you. So I'm George Lange. I got involved with this as my theme when I was president of the Wisconsin Medical Society about 14 years ago now, although obviously my patients were involved. And I'll give you an example of how valuable an agent can be for a patient. This particular patient had made it clear through a written advance directive that they did not want any heroic measures, and they named their agent. And he unfortunately went down at a major mall in the Milwaukee area, Mayfair Mall. And I can assure you that if you pass out Mayfair Mall, someone will call 911. Paramedics came and documented that he was a pulseless non-breather. They scooped him up and took him off to the hospital. In the hospital, by the time he got to the hospital, he had a heartbeat, but he wasn't breathing. So he was put on, they bagged him all the way there. Then he got intubated and placed on a ventilator and quickly got taken upstairs to the ICU. They went through his belongings and found out who his family was, and they contacted them. And they arrived shortly after with the agent, and the agent had brought the advanced care document with them that indicated no heroic measures. And they politely asked for the ventilator to be stopped. And the doctor said something to the effect, I wasn't there, so I'm quoting the family, that we have to see how this is going to work out. At that point, the family made a deal. They said, well, we're either going to go to the media about this or we want Dr. Lange here. I happen to be nearby, actually at the Lutheran home for those that are familiar, and I came over to see the patient. And I asked to see the team and the doctor, and the team came over, and I said this part of the note, I actually printed it in capital letters, that to continue without the patient's consent is an act of injury, and you cannot proceed that way. The nurses were kind enough to call me an hour later that he had been taken off the ventilator and promptly died. That is the power of an agent. I know sometimes agents may feel disrespected, but generally speaking, doctors will listen. And the agent knows that when they speak, it's as if you, the patient, are speaking, which is much more powerful than a guardian or personal representative that we'll talk about later. Thank you.
Thank you much for that introduction, Drs. Hofmeister and Lange. This is really an outstanding fit and a need in Wisconsin that is growing more and more documented. So what I'd like to do at this point is, Jai, if you would be willing to pull up the PowerPoint. We've got a brief presentation that Drs. Hofmeister and Lange are going to give us about what it is this means from a health perspective. So go to it, please.
All right. I think we can, Jai, we can go forward to slide number 3. Maybe. Chris, let me know when you can see the slides because there could be a delay on my end.
Will do. I'm still not seeing it. Jai, we've got screen sharing, but we don't see the, there it is. Now we've got it.
There it is. Okay. We don't have a lot of slides for you today, but we did put together just a few to frame the issue and then talk about the different options for advanced care planning that are available to patients and really anyone in the community. So just some background so you can see the numbers and why this is such a problem is that really nationwide, only about 1/3 of adults in America have an advanced directive, which is really unacceptably low and creates so many problems for themselves and then also for families, problems for hospitals, issues with hospital flow, and then just confusion and stress in a time of need at the end of life. And so really the part of the goal in this is to make that number much higher by sharing the message so that you can all share it with your networks as well to increase the rates of advanced care planning. Specifically in Wisconsin, and George and I have done some work on Wisconsin data, the range really varies across hospitals, anywhere from as low as 20% to as high as 60% documentation of completion of advanced directives. And this is really so important to capture those wishes for patients at the end of life. This promotes patient autonomy. It really centers care around the patient and what they want and what they don't want in those final days. It improves the experience immensely for the family. The family is certain what a patient wants. While they may not agree with it, they can respect those wishes and follow that decision to help guide the decision, because it is often very complicated. You have choices between, pursuing, very intensive interventional care versus not. And with that, there's a lot of emotions. And so this really just improves the experience overall and helps the families and patients collaborate with care providers and hospitals to reduce burden during these difficult times. We can go to the next slide. George, I'll let you hop in here.
Okay, so the I get the starfish story, and there has been a terrible storm along the Gulf of Mexico, and a lot of starfish have washed up on the beach. And there's a child, and the child is throwing the starfish back into the sea that they see. And an adult comes along and says how, there's too many starfish. You cannot possibly make a difference. The child continues to throw starfish back into the sea, and after the next one, the child says, well, maybe that one appreciates it. And that's how come I and others keep on letting the community know that people have this option to have an advance directive, to have an agent that they choose, that they tell what their goals of care are. And so the Wisconsin Medical Society has partnered with institutions across the state of Wisconsin. And we did this study along with Freighter several years ago, showing that there's huge variation, with some places with less than just under 20% of their adult population having advanced directives, and others really hovering right around 60%. From a previous study a long time ago, physicians in Wisconsin and in Texas, over 60% had advanced directives. So do doctors know something our patients don't know? And as physicians, why haven't we told our patients? My colleagues would say that we don't have time. There are things that take a lot of time. And my response is that when the patient raises the subject of an advanced directive, the correct answer from your physician or other provider should be, that's a good idea. I have one. I will send you to a facilitator, because a facilitator can get this done for you. Some people are afraid of this from the standpoint that it may cost money. This can be done for free. So those are the barriers, some of the barriers. So let's see, understanding, not planning. And, most people don't want to be a burden to loved ones. And that's why I chose the music from Oh, What a Beautiful Day, because my uncle, who was a physician, died. And that was one of the songs he chose, because he believed things get better after you die, at least for him. And he also didn't want to be a burden to his children. Most people don't want to be a burden to the people that care about them. And avoiding the conversation's not going to make this burden go away. But by having these in-depth conversations, you can get the care you want and ease burdens on those that you leave behind. And this may include family, friends, clergy, physicians. And that's how come we're reaching out to the community to see if they would like the people that they're caring for know about that they have this option if they choose to do it.
We can go to the next slide. So just some background on a few different types of advance directives available to patients in the state of Wisconsin. So there's a living will, and you can find blank copies of these documents online, and we actually have links at the end to different websites that have them as well. But a living will, also known as a declaration to health professionals, states your wishes about life-sustaining treatment if you have a terminal condition. This covers things such as life support, artificial nutrition, feeding tubes, pain management preferences. This document does require 2 adult witnesses, but an attorney is not needed to actually author this document. In the middle here, I talk about healthcare power of attorney, or the HCPOA. This is a trusted agent to make all healthcare decisions in the event a patient becomes incapacitated. And we recommend this for everybody over the age of 18. So everyone always focuses on that, 65 and over population, but really as young as you could possibly have one of these, it's important because what if, some tragic accident happens or something like that, you want to have your wishes documented. It's really, really important to have a conversation with the person that you name as your healthcare power of attorney, one, so that they are aware, and two, so that they are willing. But you can have this document. And this also covers many of the same issues that the living will covers. It also includes things like organ donation decisions. And then on the right, option 3, there's some other orders that can follow an individual into different facilities or be acted on in different facilities. There's a DNR order that is physician issued. The patient, if they are able to make the decision, they can indicate whether or not they want to be a do not resuscitate or not, but it must be signed by a physician and presented when the emergency medical services would arrive, or the POST form, which is portable orders for life-sustaining treatment. This is a medical order, it's not just a directive, and it can also travel with the patient across care settings. So there's lots of different options for patients. And again, like Dr. Lange said, these can be done for free. You don't need to involve an attorney or have a significant financial burden on your family. We can go to the next slide.
And if I could add to that, I'd like to say that it's important you give your doctor a copy. It's important that when you see your doctor the next time, they can retrieve it from their electronic health record. Because if you can't find it, that's not going to do you a lot of good. However, you should also give copies to those people that you want to have copies. Certainly, at the very least, besides your doctor, your agent should have a copy, because that will be proof that the agent is speaking with your authorization should the patient be unable to speak for themselves. And now, more recently, with Wisconsin becoming a next of kin state that we'll talk more about, you may also want to consider filling out a durable financial power of attorney, because there's been some question about whether or not a healthcare agent can sign up for Medicaid insurance, because if this is a prolonged hospitalization, maybe you need Medicaid. And there's been some question. A lot of people say they do have the authority, but some question that you get around that by also having a durable financial power of attorney.
Do you want to move into talking about Act 115?
Sure. So what I was talking about that because we have this new law, and actually, from my perspective, what the best thing about this new law is this is another reason you should have an agent, because this way you get to pick your agent. Otherwise, the hospital following this law could pick your agent, may not be the person that you wanted. Matter of fact, a colleague of mine had surgery in Minnesota when Minnesota was a next of kin state. And that actually got them to fill out their advance directive because it would have fallen to their mother. And they didn't want their mother to be the agent. And they chose a physician colleague to be their agent. Fortunately, the surgery went well and they didn't need the agent. But that's another reason that you may want to do it, because will you get the person you want? And more importantly, will that person know what your goals of care are? So another reason to fill out your advance directives.
We can go to the next slide.
Yeah.
So just a few things that you can do to support this work with your networks and communities. Part of our conversation today is to work to get you comfortable with this, to normalize the conversation. So, it's an awkward topic. It's upsetting to some people. They don't want to think about end of life issues or issues that could come up that could make them incapacitated. But the more you talk about it openly with patients and families and colleagues, the more normal it becomes, and the better it'll be later on when you have to use those documents. Knowing the different documents, you can certainly look up online with some of the links that we have on the last slide after this, the different documents. You can start to familiarize yourself and talk with others about them. Like I mentioned before, informing your POA. If you name somebody, please let them know. And also, if a patient picks an individual, it's really important to make sure that individual is comfortable doing the work. I've been in sticky situations taking care of hospitalized patients that had a POA that was activated, but that person didn't feel comfortable making the decisions, and therefore then defaulted to having conversations with the entire family, and the entire family couldn't agree, and it was a very stressful situation. And then the patient lingered there for a very long time, where individuals were not able to decide what to do going forward. And so that power of attorney, has the ability to make the decisions, and you want to make sure that it's a person that can communicate with your family and actually enact the wishes that you've put in the document. Share it with the health systems, make sure it's in your chart so that people can access it. And then there's many other organizations that you can partner with on this work, and try to bring it to your networks. It happened last week, but every year there is National Healthcare Decision Day. That was April 16th, so more than just tax day in April. So that's an important day that can bring this to top of mind to make sure that you have those documents in the right places. We can go to our last slide.
And Governor Evers actually made it a week from all of last week was National Healthcare Decisions Day here in Wisconsin. It serves as a reminder for those that have not. It also serves as a reminder for those that have. Is it time to look at your advance directive again? We have something called the 6 Ds. If your agent dies, you need to look at your advance directive because it may have changed. If it's been over 10 years, you should look at your advance directive because maybe something has changed. If you now have a major diagnosis compared to the past, maybe it's time to maybe you want to change something. If you have acquired a severe disability, you may want to change something. If you've had a chronic condition like COPD or congestive heart failure, and you've been stable for years, but all of a sudden you find yourself in and out of the hospital over the last 6 months, maybe something's changing, and maybe you need to discuss with your doctor, should I consider changing my goals of care? And then, of course, either change your form, and that's how come I said that you want to have certain people have a copy of your form. You need to keep a list of that. So if you do a new healthcare power of attorney, you can let all of those people know that you'd previously given the form to that things have changed, but most importantly, your agent. So happy National Healthcare Decisions Day last week. Sorry, we're about a week late, but we're close.
Okay.
And the Wisconsin Medical Society is willing to provide information to help people carry this message to those that they want to keep well informed.
So this slide has some images and a website up there that is free to use through the UW Extension program, the Lifespan website. It is a wealth of resources and can also link to this Planning Ahead seminar, which is for anyone in the community to register for. They do it in multiple different languages. It's virtual. This website is really, it's a great resource for patients. And then in addition to all the documents that we were mentioning before, we have a list here of other documents on the left that it would be really helpful and useful if your loved ones were aware of all of these things and kind of where they are, because when a patient passes, all of these accounts and different items need to be accounted for and actioned. And if the locations of these are unknown, it can cause significant stress and burden on family members.
At the very top of this page, we have aging.extension.wis.edu. Actually, their next 7-week class, which is 1 hour for 7 weeks, starts next week on Tuesday. I don't know if you can still register. It's free. If you want the planning document, that's $30, just so you're aware of that.
This is really incredible information, Sabrina and George. I really appreciate it. With all of this here, if I could ask you just to, between the two of you, take a moment and if there are deliverables or things that we want, a few takeaways for our audience to think about here, what are the important things to think about in terms of documents, in terms of next step actions?
Well, I'll give a plug for Sticky J is the official source of a bracelet that you can get that would indicate that you have an advance directive. That costs the price of the jewelry, and if you get a QR code on it, that'll bring it close to $50. If you don't want to spend that money, there's another company called mydirectives.com, and that will store your information for free. They're funded by various healthcare organizations because they view that these people should have access to these documents. And I haven't done it yet, but I'm sure going to use, I'm cheap, so I think I'll use mydirectives.com because that's free. But that will enable anyone in the country to access your information. I imagine if they have access to the internet, they get it anywhere in the world. They get many inquiries to see copies of this information, just so you're aware of that.
Yeah, and I think my
Thanks.
biggest takeaway is if you go through the healthcare power of attorney document, make sure that your doctor has a copy of it, so it's in your medical record, and make sure your power of attorney has a copy and is aware, because between the two things, hopefully when it's needed, it will be able to be found.
And tell your family and friends you've done this so they will support your agent. And it gives them a chance to kibitz while they can still kibitz with you. And then you get to tell them that it's your life, your choice. And which is a very powerful message. And yeah, I'd be happy to. The medical society is happy to provide information and or people to try to help you present this information that people may want to know about.
That's great. That's really helpful. Thank you, you two. Jai, I think we can go back to the normal screen. And then I've got a couple of questions that we've come up with just for you two to answer amongst yourselves. And then we'll see if anybody has questions in the audience, if that works okay.
Sure.
So one of the next questions we have, and I think part of what you just gave us might address part of this, is how can people effectively engage within this community? Does it start with doctors? And how do you build that relationship, not only with providers, but how do you build relationships with people and families that might need to fill out healthcare power of attorney, advance directives in a way that builds trust? Because there are a lot of people for whom this is a topic they don't want to talk about, for whom this is something that is that's just not something discussed. So what does building trust look like in that space?
So I don't think this definitely doesn't have to start with doctors. It's very easy from a doctor's perspective to have the conversation because your entire conversation with the patient is surrounded around their health. But really, the word trust, you mentioned the word trust in that question multiple times. That is so important. It can be any trusted individual in the patient's network that can have this conversation and start this work. So we mentioned specifically like clergy members. There could be a trusted associate at work. There could be a teacher in a person's life. Really, anybody who is comfortable with the patient and can start having that conversation, even if it's just a mention this day, and then maybe the next week it's something else. Like it has to build over time if somebody is very uncomfortable having that conversation.
They just have to understand that no one should tell you how your goals of care. Your goals of care has to come from you because we're here to serve you. And as it was said earlier, if we don't know what a person wants, we'll do everything, which may be what they wanted. I did have a patient once that I met for the first time when they came in the emergency room with a fever, and they came from a nursing home. And I talked to the nursing home, and they'd lived there 5 years in a persistent vegetative state. And they were being cared for with tube feedings and Q3-hour changes of position to protect the skin. A doctor doesn't have to treat a fever. It's an option. I talked to the patient's agent, who was the spouse, and they assured me they wanted everything. So besides antibiotics, they would want a ventilator, they would want CPR. I treated them for what turned out to be a bladder infection, and they went back to the nursing home. They never had a catastrophic event. And I did make the mistake of asking the spouse how come that's so important to them? And they believe the more you suffer before you die, the quicker you get to heaven. Now, I don't prescribe that, but that's what they told me. I had my orders. I took care of the patient. Not particularly proud of it, but if that's what people want, that's fine, because we are here to serve. And so the patient got what his agent told me they wanted.
Well, and to just dig a little deeper on the question about building trust. How do you address cultural differences that might impact engagement and conversations about death and dying?
I'd ask them, how do they feel about death and dying? The fact of the matter is, everyone on this Zoom call is going to die one day. And some people have a voice in how they feel that they would like to die if they know their options.
And just to move a little bit further to as far as how can people, we've talked some about physicians, but how can people, like in their communities, support the work that's being done by the two of you?
So I think if you are involved in a faith-based organization, that is a really great avenue to have this conversation. So contacting, clergy members or pastors or rabbis or things like that, and supporting information sessions, whether they be virtual or they be in person. That's a great place to start, where patients have a lot of trust in those organizations. You can do the same thing in, different community organizations, different schools, things like that. That is one way to support the work. Just bringing it into a place that feels familiar to the patient, that they are willing to go and engage with some kind of session, is one way that people can do it.
And leaders in faith-based groups, whatever the religion, they're in the same position as doctors frequently, because we may have a really critically ill patient in the ICU, and the intensivists want to know what the patient would like. What should we do at this point? Because the prognosis may be very poor. That doesn't mean it, you're not always certain, because that's how life is. And so sometimes those families will go to their faith leaders and they'll say, what do you think we should do with our loved one at this point in time? And usually the faith leader will say, well, what do you think your loved one would want? So many faith leaders actually think this is not a bad idea to have these discussions, because they're in the same predicament the doctors are. And do they really want to be there when all you had to do is ask ahead of time? And I'd like to make a little comment about how to choose your agent. Your agent should be, the number one criteria is somebody that that you trust. Part of that trust is, will they follow your goals of care that you determine and you tell them what they are? So if they say, oh, I can't do that, well, then you need a different agent. I'd also like an agent that's willing to listen to the doctors. And if there's something they don't understand, they're willing to ask the doctors questions. Why do I say those two things are important? That agent needs to know what the situation is so they can follow the patient's goals of care. So that's usually how I tell people to pick out their agent.
Thank you. That's really useful information. For the both of you, whether it be personal or professional experience, what have you found has been most effective at encouraging patients or community members to complete advanced directives?
Unfortunately, I've seen two situations that are effective. One is if you are a part of a situation that goes badly, right, where you witness somebody who did not have an advance directive, or someone in your family, it's not clear, their power of attorney is not, assertive enough and able to enact the wishes of the incapacitated patient. That is often huge motivation for the others that were involved to get that done. But it's much more effective if that's not the case and that's not what happened. So for me personally, it's repeated conversations with patients, even if you just introduce it, and you might have to give them the packet of information 10 times before they actually fill it out. But I'll give it to them 10 times. Unfortunately, we have to kill some trees, but if I have to keep bringing up the topic in order for you to feel comfortable with it, then that's my job.
Two things I'll add. One, if you go to the Wisconsin Medical Society website, which is wismed.org/ACP for advanced care planning, we have free forms available that meet all the Wisconsin laws, but it's a lot easier to read. It's available in 15 languages, and it's what's called a bilingual translation, because one paragraph's in English followed by the language for those that have various foreign languages. I think about a year ago, I was reinforced in all of this because my father-in-law lived with my wife and I for about 8 years before he died last February. And we knew clearly what he wanted. He was a DNR with all the appropriate things done. He suffered a hemorrhagic stroke and he was in hospice at Freighter and died a few days later, getting the care that he wanted. And it was easy because his son and daughter both knew, as did his son-in-law and daughter-in-law, and we kept him as comfortable as we could, along with the help of the staff there. And it was everyone was so comfortable with what was going on. There was no disagreement because we all knew the plan.
Thank you. Are you looking for organizations to partner with you? And like what opportunities might there be for organizations to help you with your work?
We're definitely looking for partners. As George mentioned, the Wisconsin Medical Society multiple times. The Wisconsin Academy of Physicians is the organization that I'm a part of. Anyone can reach out to us, and we have resources to bring in speakers, to give actual physical copies of things, education to your networks. We are eager for more partners in this work.
And if your network has people who are already reaching out to the community and teaching the community various things, those people can be taught to do this too. This does not require a medical degree to tell people that they have the right to do this.
To that end, are there partners that you don't have currently that you're hoping to engage with? Are there sectors that present opportunity for you or for this process?
Well, I'm chair of the Wisconsin Medical Society Steering Committee on Advanced Care Planning and Advance Directives. And so we have input from people from all over the state, mostly social workers, but other people too. So we get to find out what they're doing that works in their community. The Fox Valley is famous for reaching out to high school graduates who are 18 or older usually, and to let them know that it's important for them. And there's actually a bonus here because then they tell their parents, and their parents think, oh, maybe this is something I should do. And it may work its way up the generations. That's something that we could certainly be doing more in the Milwaukee or greater Milwaukee area.
Yeah, I was going to add the younger demographic. I feel like we're connected with healthcare and with, different geriatric associations, but the younger demographic is definitely, I think, a big area of opportunity.
By the way, if you're in the military, and for any veterans on this call, I want to thank you all for your service. Military understands this better, but sometimes they forget because one of my friends' son-in-law is now in the National Guard, which is part of the military, and during basic training, they filled out their own advance directive.
So we'd like to open up to the audience as far as for questions. Feel free to put some questions in the chat. And while people are thinking of some questions, I know that Chris asked you this after the slides or during the slides, but again, is there anything that you want to highlight as far as a takeaway for this session?
I'm going to give my father-in-law another plug here because although he did not take the planning ahead course, he had made sure, with the help of his daughter, that all of his tax information had gotten in to the accountant. So we didn't have to deal with that. I don't know if he had a premonition because you really don't know when these things are going to happen. And he had organized his finances to make it as easy as possible for the next generation to handle these things. So he gets lots of credit for that, which made our life a whole lot easier. So a plug for the planning ahead course.
Like that, planning ahead in all capacity. We have a question from Dr. David Nelson. How do we better build capacity with medical students and physician residents in this important area?
That's a really good question. not being involved in the curricular education committees. I don't know if there's modules on the medical student side on this. At least I can speak to residency training, and we are working to include this in quality improvement curricula with recurring projects to increase rates of advanced care completion amongst patients, and as well as having courses around centered around having difficult conversations with patients. So that's some work that we're doing, on the residency side. And I think that could also be easily translated into the medical student side as well. Actually, Dr. Lange and I worked with a medical student who has since graduated from MCW, but that was a few years ago on our initial work within the Freighter health system to get baseline rates and to see some of those differences in completion based on a patient's area. So I think that there's ways to get medical students involved through research projects and other educational courses too.
And I want to say I've been working with Freighter and the medical school for some time now, and it's been wonderful, especially Dr. Hofmeister and Dr. John Raymond and others. But some medical schools, not MCW, some medical schools actually require the medical students to do an advance directive, such as Minnesota does that. As an example, and Mayo Clinic also has a medical school, they require that. Why wouldn't a physician, and I mentioned earlier, it's wonderful that just over 60% have advance directives. What's wrong with the other 40%? I bet you they're going to die too. And I think we owe it to our patients that all of us and everyone in healthcare should have an advance directive, because why wouldn't you? But one, to get the care you want, but also to ease that burden on those people that may be left behind. And finally, as a healthcare leader, it'll give you the high ground when you say an advance directive's not a bad idea.
Excellent. Thank you. Looks like we've got a hand up. David Ferguson, can you come on and ask your question, please?
Yeah, thanks. Some comments. Just an excellent topic. I really appreciate it. Took some notes on some resources, but I thought I just a couple of things where, I talk about it with the medical students in my courses because I find that, many of them don't have them and haven't heard about it. So that's kind of where I start. But some of the things that I've experienced that I just would comment on is that there's no process necessarily for deactivating a POA, and I've run into some issues there. So somebody who has a very, capable person, has some borderline MCI, but had a metabolic encephalopathy, and then resistance on the physician and family members when this person had regained capacity to make decisions. It took a long time to get the POA deactivated, which means they can't make appointments for themselves. They're essentially treated as a person that doesn't have some autonomy of their decisions. So I don't know. There's sometimes I think some issues about when, can they be deactivated and what that process is like. I like the point about scans not being available. Just because it dropped it off doesn't mean it ends up in the hospital system. I've run into that on several occasions where the agent documents aren't available. The other thing I'm finding is that there's some inconsistencies across systems on what they're asking the agent to do. I was alternate for an individual, and the sister was not in the area, and the hospital insisted that they be there in person for all the visits, and that agent had to resign. And so I stepped in, but who's the best person was probably the family member to be in that role. I'm seeing that more where they're requiring, so no telemedicine, like no Zoom, no phone calls. You have to be in the room, which is inconsistent with even within the same system. It's by department policy. So that's, I think, a challenge for agents. And then finally, I just saying, the ADRC is a great place for some of this, but I guess it's just a fantastic topic. So I really appreciate you bringing this to everybody's attention. And guardianship. That's the other. I was going to say I'm sorry. I was going to say the other thing is that people don't realize what happens sometimes if they don't take care of this, and they end up in the guardianship world and the expense. And some of the, those guardians sometimes have caseloads of dozens of individuals, and they stop by periodic. So we have a real problem kind of with that guardianship world too.
Yeah. So with respect to ADRCs, we have 72 ADRCs in Wisconsin, one for each county. And some of the counties are very proactive with respect to advance directives, and others are not. And they say it's a matter of money.
Another question from the chat. How can health departments provide support?
Provide information about how they can go about it. Refer them to the Wisconsin website I mentioned earlier, or planning ahead. Have people that are trained to answer their questions. Talk to their local hospitals and see if they can refer patients there. You know, if I had usually my patients are the same system, but I could deal with any system. And if they don't actually have to talk to the doctor. If they call the doctor's office and they say, I want to talk to a facilitator to help me fill out an advance directive, they can arrange that for free. Matter of fact,
Go ahead.
If you go to the Wisconsin website, we have sites all over the state of Wisconsin where you can go to get local information, where you might be able to get help with this. It's just been updated actually as of April 15th.
And I have a question that came via email. So it's, my father had an activated power of attorney which named me as the agent. When he was in the hospital, I found my position was not respected, although the health agent was activated. I found decisions made by the medical team were based on information they obtained by my confused father or other visitors. I found I had to get rather aggressive to enforce that I was the agent. I'm sure I was identified as that difficult daughter, but I had the responsibility given to me by my father. My father was very thoughtful in setting up his agent, and we had discussions about his wishes. How is the healthcare agent communicated to the health provider team, and are providers clear about what that means? How could I have been clearer? I had documents and had made my position clear to the attending physician.
Yeah, so typically in the electronic medical record, it's noted healthcare power of attorney activated. It's in this banner bar. It's very bold so everyone can see it and who the agent is. And especially when somebody's in the hospital, social workers will activate that and make sure that the healthcare team is aware. So for inpatient settings, it is clearly communicated to the team. So I'm not sure what the challenging situation was in this case that the team was maybe unaware, or that this individual had to advocate more. Go ahead, George.
Well, did they say that the patient had regained capacity? If they did, then there's a form they have to fill out, and that would change it, and the agent would then have to step down. It's a little bit like we've had two presidents now that while they were actively in office, they had traditional colonoscopies done. So indeed, their vice presidents were in charge for that period of time that the president really was not available. And when the doctors cleared the president that they could resume their presidential duties, the vice president then went back to only being the vice president. So if they had said the patient had capacity and they're willing to document that, then the agent does have to step aside. I have the feeling they didn't do that. And if they didn't, then the agent, very much like the example I used, needed to bring in somebody that would reinforce that the agent does get to speak for the patient. And maybe there was even sexism there for all I know. I don't know. But it was wrong. You know, to use the bad example, I throw the flag, and that's 5 yards for illegal procedure. If you know the agent and the agent's empowered, you got to listen to him, even if you're not happy about it.
Do we have any other questions from the audience?
I have a question. And you might have mentioned this already because I joined a little bit late, but I'm just wondering, like, where do you find the capacity forms, like the state form for capacity? Like, I saw a patient on the outpatient side where I needed to sign off saying that they didn't have capacity to make decisions anymore to activate their POA. And I had another physician who also saw the patient who agreed, but I can't seem to locate like a capacity form, like what we sign when we're in the hospital for like the outpatient side.
Yeah. When I was in practice, the hospital provided these forms for me. And they were very simple forms. I don't think they came from DHS. I think they came from the hospital attorney, but I could be wrong. Maybe Dr. Hofmeister knows.
Yeah, no, I was just going to say it's a hospital provided form that you can utilize in the outpatient setting as well. But I don't have any more clarity than that. Sorry.
then I would say it might be helpful if some of the like clinic, hospital affiliated organizations also had that, because that was like a big deal for my patient's family, is that we didn't have a copy of a form to provide to whoever was asking for it. And so my clinic note I thought would suffice, but they, were still asking about a form. So, okay.
Sure. That's a really good question.
Yeah, excellent question.
Yeah, we'll have to follow up and see if we can find anything.
Well, if there are no more questions, I just want to say thank you, Dr. Lange and Dr. Hofmeister. This has been an incredibly informative and really an important topic. I'm going to, full disclosure, I'm excited about potential partnership with the both of you in thinking about how we train community partners to effectively walk with people through this process to make certain that we're getting more 80s completed. Thank you for your time today, everybody. We really appreciate you being here, and please spread the word. Look up the resources that have been given to you here, because this is really an important thing for us to consider.
Thank you.
Jai, do you have a, oh, I'm sorry, Jai, do you have a slide for us? All right, so the recording of this presentation is going to be posted soon on our website. Please Google MCW-CE Spotlight Series, and please join us next time for our next Spotlight. Thanks again to Drs. Lange and Hofmeister, and have a great day, everybody.